covered the sort of the normal aspect, the normal childbirth, and we also went through antepartum hemorrhage and cord prolapse. So today we've got the more complicated aspects of things. So this morning we're going to go through shoulder dystocia and postpartum hemorrhage in this session, and then this afternoon, if you'd like to come back, we're going to go through eclampsia and breech this afternoon as well. Right then, so shoulder dystocia then. It's probably one of the things that scares everyone the most. What do we do if this baby does not deliver after the second push that this woman gives? It's an extremely frightening situation for us all to be in, and it's a frightening situation for me to be in, even as a midwife, because it is very scary, and for you guys it must be even worse. I cannot imagine. So what have we got with a shoulder dystocia then? Basically, it's a bony problem. We've got bone on bone, we've got the anterior shoulder of the fetus that gets wedged underneath that symphysis pubis, which prevents the delivery from occurring. So in order to get this baby to be born, we have to carry out certain manoeuvres in order to get this baby out. You're not going to get this baby out purely by pushing. This baby's not going to come out just by pushing. You're going to have to do something to facilitate this birth. We cannot say who's going to have a shoulder dystocia. It's him heckling at the back. We cannot say who is going to have a shoulder dystocia. We just don't know. There is not one of those things where you can line 50 women up against the wall and go, oh, you'll have a shoulder dystocia, you won't, you will. You can guarantee that the one woman that you think will have a shoulder dystocia is the one woman that doesn't, and the one woman that you think, oh no, it'll be fine, she's got a tiny little baby, she'll push that out, no problem, will be the woman that will. They will always catch you off guard. There are certain things that do make them more likely to occur. If you've got a very short woman that's got an extremely large baby on board, you're more likely to get a shoulder dystocia. The larger the baby, obviously, the more likely you are, because the larger the baby does tend to cause more problems. And that as well, with what Martin was just talking about, diabetes. Diabetes in pregnancy is a very common indicator for a shoulder dystocia, purely because women that have gestational diabetes tend to grow larger babies. So again, larger baby, more risk of the problem happening. The incidence of shoulder dystocia happening is quite rare, you'll be glad to know. It's about 2 in 1,000 births, but that does vary by region, believe it or not. As in Shropshire, where I work predominantly, we do tend to have more shoulder dystocias, purely because in Shropshire we tend to breed larger babies. Most of our babies are around the sort of 3.54 kilo mark. So when you've got larger babies, you do tend to find that you have a more chance of getting a shoulder dystocia. Right. So what do we do then? A baby that's going to have a shoulder dystocia will progress normally in labour. They'll have a normal labour just like you would if it was going to be a normal birth. But what you will see is a few classic signs. As the baby's head is being born, you'll get the usual sort of coming backwards and forwards of the head, like we were saying yesterday, that if you've got a first-time mum, that head will come forwards and then slip backwards. That's quite normal. Quite normal for the head to come forwards and then backwards, as all those perineal muscles are all stretching up to allow for the birth. And then what will happen is, classic sign of a shoulder dystocia that you will get is, if the baby will come through, you get what's called a turtlenecking sign, which is basically when the baby's head delivers, but because that shoulder is then stuck behind that symphysis, the baby's head will then retract back in, as if it's a turtle retracting its head back into its shell. So you get what's known as a turtle sign, where the baby's head will physically burrow back into the perineum, and you'll see it classically pulling back inwards. Classically, you'll see an extremely large head as well, which is obviously the large baby, but the telltale sign is this baby's head pulling itself back in, because obviously it's stuck behind the shoulder. So, what do we do then? The most important thing to remember to do is you have to keep calm. It's really important, and it's very easy for me to stand here and say you've got to keep calm in this situation, but it is really, really important at this point that you take a deep breath, stay calm, because these certain steps that need to be followed have to be followed in a logical progression in order for you to help facilitate this birth. What will happen is that the baby's head, again, will rotate to either the left side or the right side, and it's important for you to know which way around this baby's facing. You need to know what alignment the baby's shoulders are in, because in order to carry out the next procedure after the McRoberts, you need to know which way around this baby's looking. So, you've got the baby's head out, the baby's head showing you the turtle sign, she's pushed and you've not got a baby. The next thing you need to do is, after she's given 2 pushes and you've not got a baby, is to put her up into the McRoberts position. We all see the McRoberts position? We all know what the McRoberts position is? Okay, basically this is where you have to get the lady lying fairly flat on her back, so she's got to be flat against on the surface, whether she's on the bed or whether she's on the floor or whether she's on a chair. She needs to be laid flat. And then you have to take both of her legs. Someone needs to be on each of her legs, so you need somebody else. It's a two-person manoeuvre. You have to take hold of her legs, and you have to take her legs back as far as they physically will go, up to the side of her abdomen, and pretty much up round by her ears. That's as far back as they've got to go. The natural movement of that will, round a bump, will automatically sort of abduct her legs outwards. By abducting her legs outwards and moving her legs backwards, you're naturally causing her pelvis to tip in a backwards motion. So you're raising the pelvis upwards, causing the diameters inside to change, and hopefully what will happen when you do that is that that baby's shoulder will be freed and the baby will be born. In around 65 to 70% of shoulder dystocias, the McRoberts position alone will work to deliver the baby. That's great, fantastic, you've got a baby. However, it doesn't always work. So then we have to move on to the next step, which is why I said it's really important for this next step that you know which way round this baby's facing. Because the next step that you're going to do is to apply suprapubic pressure. Now the rationale behind suprapubic pressure is we're applying pressure 2 fingers above the lady's symphysis pubis, firm, steady pressure as if we were doing CPR. And the idea of doing this is we want to compress the diameters of this baby's shoulders. So we want to compress those diameters down in order to let that shoulder slip underneath the symphysis to be born. So it's no good you pressing against the baby's face, because all that will do is widen the diameter, and that's the last thing you want to do in this situation. So you want to narrow that diameter by pushing in the direction of the baby's face, making that diameter smaller. Hopefully, by pressing constant steady pressure, she's going to give 2 more pushes while you're doing that constant pressure, and hopefully your baby will be born. While you're doing that pressure, she still does need to be in the McRoberts position as well. She needs to remain in the McRoberts position while we're doing this. However, if that doesn't happen, you need to be thinking now in the back of your head, this baby's not come with the first 2 steps. We need to think about our escape route. So that needs to be in the back of your head while you're doing this. So the next step that we need to do is then to apply intermittent pressure. As if you were doing CPR, again, CPR grip, 2 fingers above the symphysis and applying intermittent pressure just above, as if we were doing CPR. And again, further 2 contractions with her pushing to try and deliver this baby with the intermittent pressure. Okay? And hopefully, you'll get a baby out. Now there's one more manoeuvre. If you still don't get a baby, there's one more manoeuvre that you can carry out, and that is then to roll her onto the all fours position. By rolling her over onto the all fours position, you sort of give her that little bit of a time to sort of manoeuvre around and give her that bit of jostle, and hopefully that might be enough to sort of help that shoulder dislodge and slip underneath the symphysis. But the idea of rolling her over into the all fours position is that you've then created this space in the sacral hollow here, and what you're going to try and do in this position is to try and deliver the posterior shoulder. So rather than delivering the anterior shoulder that is still wedged quite firmly under that symphysis, because you've gone all this way and you've not got the baby out, you're going to try and deliver the posterior shoulder which isn't wedged. So we then apply the traction as if you were delivering the baby normally, to then try and deliver this shoulder just here, which hopefully should be enough to help you. It's not been very well. Here we go. Not with the baby around, then hopefully that posterior shoulder will come out first to help you deliver your baby. Now if you've had to do all those manoeuvres and all those procedures, it's more than likely that you're going to have a baby that is quite shell-shocked after all of that time. So again, you might need to perform some form of neonatal resuscitation after a baby has had this sort of degree of trouble getting into the world. Again, we would do exactly the same as we would if it was a normal birth. We'd dry and stimulate the baby exactly the same. Dry towels, nice and nice and firm pressure onto the baby. It's not sort of gentle tapping, it's a good firm rubbing, really rubbing all over. And what we were talking about yesterday is actually not cutting and clamping the cord straight away, because obviously we don't cut and clamp straight away. We always leave the cord to try and stop pulsating if we can. But obviously, in this sort of situation, if you need to carry out some form of resuscitation, if you can allow the baby to have some of its cord blood back, because while this baby's not actively bleeding for itself, you've still got an oxygenated blood supply coming from the placenta from mum. So baby is still receiving some form of oxygenated blood supply while they're waiting to establish their own respirations. It's not in the Resus Council policy as yet for neonatal life support. However, I believe that with the research that's coming, it soon will be. So we try and stimulate the baby, and then hopefully everything will be absolutely fine. Baby put skin to skin and normal routine care, and toddle off to hospital as you would normally. One thing I didn't mention at the beginning of this, if you think that you're going to run into trouble, if you think this is going to turn into a shoulder dystocia before the woman has started to give birth, it's really important that you contact your control and request your midwife. Now, I know in a lot of areas that midwives don't come out as much. However, if they tend to know that there's a crew in trouble, they will try and send a community midwife out if they can to come and assist. Because there are certain different manoeuvres that midwives can do that I'm not allowed to teach you because they're internal manoeuvres. But there are certain things they can try, and you never know. There might be a midwife doing a clinic in the doctor's surgery around the corner from you. So it's always worth giving the control a try to see if they can try and find you a midwife. If you get to the situation where you've tried all your manoeuvres and you still haven't got a baby, you then need to rapid extraction of this woman from the house and get her out off to hospital. Oxygen, supplementary oxygen to try and help supplement the fetal circulation as well. Now, this woman is probably not going to be able to walk particularly well. However, if she's got her head sticking out, she's also not going to be able to sit down on a chair either. So the easiest way to do this, we've sort of established, is if you get her to walk, if she's typical, because they're always in the back bedroom upstairs, aren't they? The smallest back bedroom, back of the house. The easiest way to do this is if you get them to walk backwards down the stairs. So walking backwards down the stairs, but just be careful. You don't take your hands very far away, because that sort of crabbing motion down the stairs might just be enough to sort of jiggle that pelvis and facilitate your birth. So whatever you do, don't take your hands too far away, or you might end up delivering the baby in, and even though it's got its own bungee cord, it's not recommended. Right, okay. Has anyone got any questions about shoulder dystocia? Because if you go backwards, you've got more chance of controlling the baby if the baby's about to be born. And it's also a better position for them, for you to sort of manipulate them if they do decide to be born that way. And it sort of can help with that sort of manoeuvring the pelvis and sort of get them going backwards. Because they're not going to be able to sit on a chair. Even if it is one of the nice Furno ones, they're not going to be able to sit on it. Any other questions? No? Okay, right then. Moving swiftly on. We're now going to talk a little bit about postpartum haemorrhage. So, again, with a postpartum haemorrhage, we don't always know when they're going to happen. They're more common after a very long, difficult labour. You're more likely to get one if you've got a very large baby, and you're more likely to have one if you've had a postpartum haemorrhage in a previous pregnancy. They're more common if you've got anything that makes the uterus larger than it should be, like I said. So if you've got a large baby, or if you've got twins, again, you're more likely to get it, because anything that makes that uterus larger than it should be, you're more likely to have that uterus bleed afterwards. Women that have had sort of more than 2 to 3 babies, again, you're more likely to have a bleed, purely because the uterus is a muscle like everything else. So that uterus has to use its force to then contract down and stay contracted down after birth. So the more that that uterus has to expand and contract, sometimes when ladies have had sort of 2, 3, 4 subsequent pregnancies, that muscle decides that, do you know what, I don't really fancy this staying contracted lock, and it doesn't contract as well as it does when it does it the first time round. There are 4 key components to what causes a postpartum haemorrhage. Anybody, any ideas? 4 things? 4 main reasons for a postpartum haemorrhage? No? No, as in what the physiology behind them, what causes them. No. The first key one, 70% of postpartum hemorrhages are caused by atony, so it's atonic uterus. So if you've got a uterus that's not contracted, 70% of the time a postpartum hemorrhage is caused by a uterus not contracting back adequately. So they're known as the 4 T's. So you've got tone. Second one, any ideas? Another T? Tissue, yeah. Big one, tissue. Any parts of the placenta, anything that's left behind, any parts of the placenta, membranes, anything like that. The uterus is very, very clever in one respect because it says, oh, there's something there that's not supposed to be there. So what it does is it carries on bleeding to try and bleed out whatever's in there. So you tend to find if there's any parts of placenta or membranes or anything left, it will get the bleeding to continue until she passes such a big clot or the piece of placenta or the piece of membrane that is there causing that uterus to carry on bleeding to try and get rid of it. So it's quite common to get sort of quite large clots as well when you're having a postpartum hemorrhage because that is the body's way of trying to get rid of everything out of that uterus to try and make it contract down. Next one, another T, tears, trauma, yes. Key one is trauma. They tend to be sort of more external tears that we tend to get. They don't tend to be tears higher up. But again, a tear to the perineum or deep into the vaginal wall can actually bleed profusely. And the main thing we can do for tears is obviously pressure. So if you see you've got a visible external tear that's got a blood vessel that's leaking, the main thing you can do is apply pressure, maternity pad onto that and get it to pop her legs together. It's the only way you're going to be able to compress it effectively. With either physical force onto that tear or get it to put the pad on and clamp her legs together. Last one, only 1%, it's thrombin, clotting factors, any ladies with clotting disorders, more common in ladies that have got a condition called HELP syndrome, where all their clotting factors go to pieces, which is a subsequent on from preeclampsia and eclampsia. But again, ladies that have got low platelets, thrombocytopenia, anything like that that's going to mean that their clotting factors are not adequate, again, can cause a postpartum hemorrhage. So what do we do then? I've got a little, I've got to remember which one's which now. Oh, they've all leaked. Right. So, when do we call a postpartum hemorrhage? How much blood does a woman have to lose in order to call it a postpartum hemorrhage? Close. Everywhere's sort of slightly different now. 500 mils, we say. 500 is the postpartum, but in some units now, in maternity, they're actually saying over 1,000 mils and not classed the postpartum hemorrhage, so they've lost 1,000 mils. But in regards to us, it would be 500, which actually, when you think about it, sorry, I've got to try and not get food colouring all over my fingers now. Right, rough representation. How much would you say on this sheet? So you've delivered your baby and you got this much on your info sheet. How much would you say is on there? Who said 300? Spot on. Yep, 300 mils. That's 300. So that actually looks quite a lot there, to be fair to me. I think that looks quite a lot. So it's really important in these situations that we don't overestimate these blood losses, but say that is 300 on that one. Warm in trouble, all over the carpet. You've got to remember though as well that at delivery there's not only going to be the blood loss from delivery, there's also going to be a lot of liquor that's around from the baby. There might also be a bit of urine, a bit of faeces, so it's important that we don't take those into account when we're talking about postpartum hemorrhages as well. So what do we do? When we get to a woman that's lost up to sort of about the 300 mark, so we're getting to that point where she's lost the 300 mils mark, the most important thing that we need to do is to check to make sure that her uterus is well contracted. So like we said, 70% of postpartum hemorrhages are caused by an atonic uterus. So it's really important that we need to make sure that that uterus is well contracted. Now the easiest way to find a uterus is if you start at the umbilicus and then start to work your way down. Side of your hand, whichever is your dominant hand, start at the umbilicus and work your way down. As you're working your way down her abdomen, you should come to something around halfway between that feels like a cricket ball. What you want to feel is like a cricket ball size, and it should be rock solid like a cricket ball. If you don't, if you come to something that feels soft and sort of squishy and what we call boggy, that's an atonic uterus. You've got no tone in that uterus, so we need to make that uterus contract in order to stop that bleeding. And the way we do that is find the top and we dig into the sides. This is going to be quite uncomfortable, so you need to tell your woman that it's going to be uncomfortable when you do this. Dig into the side, squeeze down and massage the uterus, and you will feel as you start to massage the uterus.
This is an organiser announcement. Could Emma Nichols please return to the organiser's office? Thank you.
Right. So as you start to massage the uterus, so just rubbing and squeezing as you're going, you will start to feel the uterus firming up underneath your fingers, and it will go to sort of cricket ball size and feels hard and solid like a cricket ball. It's important at this point, once you feel it gone hard and firm, that you keep an eye on it and you monitor the situation, because once the uterus has gone atonic, it might go atonic again. So it's really important you monitor it. As you are massaging the uterus and as you're massaging that and making it go firm, what you might find at that point is you might get some clots that will appear as well. That's quite common, that's normal, that's nothing to worry about. You want that to happen because, like we said before, if there's any bits of placenta or membranes, they need to be expelled to come out and help that uterus contract down fully. So we're massaging the uterus, keeping it nice and well contracted, and hopefully it will stay contracted, but like I said, you need to keep monitoring that situation. If you get to a point where your woman has lost, say, sort of 400, getting onto the 500ml mark, this is the point where you need to be thinking maybe this woman needs cannulating and we need to start thinking about getting gone pretty soon. Okay? Large bore cannula, as large as you possibly can get. So you've got to remember again that these pregnant patients are designed to deal with blood loss after birth. So they're designed to lose up to 50% of the circulating blood volume without any significant changes in their observations. So you can find that I've had women that have sort of put out up to a litre onto the floor and they're still sat there cuddling their babies going, "Can I have my cup of tea now, please?" And you're sat there thinking, no, not just yet. We'll just stop all this happening first and then you can have your cup of tea. So don't be alarmed if they're sat there and they've not got any change whatsoever. Once you're moving and you're getting on to the stage where you're moving on to transport these ladies to hospital, if you've got a lady that's lost sort of over 500 mils, she does then need to go to an obstetric facility, not a midwife-led unit. Because if she's had a postpartum hemorrhage, she needs to go to a place where they can monitor the situation, and it could be that she needs to have a hormone drip to help keep the uterus contracted and prevent any further blood loss. So again, it's important that she goes to an obstetric facility and not a midwife-led unit. Once you're on your way, it's important that you do give them a call and let them know that you're coming, what's happened, and also if you can give them a rough estimation of your blood loss as well, so that if you get to sort of like the 1000ml mark, that they can start thinking about getting drips and everything ready, maybe even involving sort of the different teams, getting the doctors and everybody ready for when you arrive. There are also little things that you can do to help prevent the blood loss as well. If you can get the mum to put the baby skin to skin, breastfeeding as well, encouraging them to breastfeed, that will increase the natural oxytocin, and the natural oxytocin will help to keep that uterus contract as well. So little things that you can help to do. Has anyone got any questions? The lady stand up front says if you've got a very large lady, it's sometimes difficult to feel. Yes, it can be sometimes difficult to feel. You do need to go in quite deep, and it is important that sometimes if you've got a lady that's got quite a bit of mummy, if you scoop the mummy back and then go back underneath, that's the easiest way to do it. So go down underneath the mummy and then right the way down at the umbilicus and then start to feel your way down. You do need to get down really deep to start massaging that uterus, because you have to be able to get right through to that muscle. I've had a couple of questions about this. It's not in the PGDs for use in pregnancy. However, they're not pregnant anymore. So I don't know, it would be up to the individual trusts if they choose to use it or not.
Use what?
The tranexamic acid.
Oh, okay.
Yeah, I believe it has been used postnatally, but I haven't seen any papers or anything about how. She's asking about tranexamic acid. Syntometrin, this lady's just asking what point do we give syntometrin. Syntometrin is one that you give after you've cut and clamped the cord. So you can't give syntometrin until you've cut and clamped the cord. Yeah, so you would only give that after you've delivered your placenta. Yeah. Yes, it can be used. Yes, you can do. But you have to be careful that you don't give syntometrin to a woman who's hypertensive. Very, very important. If anybody uses syntometrin, we do not give syntometrin to a lady that's hypertensive because it would just send them even more hypertensive. Any more questions? Yep. It can be, the gentleman was asking how would you describe the discomfort when you're doing massage. It can be quite uncomfortable, and if they've got the Entonox there that they've been using for their labour, you can give them the Entonox back and explain to them that what you're going to be doing might be quite uncomfortable, and that you can use the Entonox while you're performing it. Yeah, no problem. No? Anybody else? Sorry, Richard. It's moaning I'm late now. Thank you very much, everyone, for listening. Thank you very much for coming.